Good morning, everyone, and welcome to the Royal Brompton Grand Rounds. I am very pleased to have with us today Professor Suresh Senan, who is a radiation oncologist at the University Medical Center in Amsterdam. And he is here to talk about integrating radiotherapy into the management of resectable lung cancer. It's a real pleasure to have you with us today, Professor Senan, and we're really excited to hear your insights in this topic. Just to say to everyone, if you do have any questions, as always, please do post them in the chat. We'll have a short presentation followed by some time for questions and discussion. So your questions are always welcomed. I'll hand over to Professor Senan to get started.
Thank you, Dr. Ashrafian, and thank the Brompton Hospital for this very kind invitation. It's a challenging topic, integrating radiotherapy into the management of resectable lung cancer. Lots of new data in this space, but fairly inconclusive. So these are images of the center I work at. And let me see whether I get this down. Yes, these are my disclosures. All payments are to my institution. So new treatment strategies in locally advanced non-small cell lung cancer have changed the treatment landscape. There are several clinical questions which remain unanswered, particularly in patients with N2 disease and with borderline resectable, whatever that is, locally advanced non-small cell lung cancer. The role of radiotherapy in resectable and operable locally advanced non-small cell lung cancer is undergoing a critical reevaluation at present. Early in my career, we were waiting the results of three landmark trials, the intergroup trial, EORTC and ESPA2, in stage 3 non-small cell lung cancer, which were a head-to-head comparison between surgery and a non-surgical chemoradiotherapy approach. They've all now been published, and it's a stalemate. There was no overall survival difference. And now we have these really exciting data in operable patients, so operable upfront, with overall survival benefit reported in the Checkmate 816, Keynote 671, and the Rationale trial. So these exciting times are tilting the balance towards a more favorable surgical outcome. But one must not forget that in patients who were considered inoperable, definitions may have been imperfect in the Pacific. We have 5-year survival for patients who receive consolidation durvalumab for 12 months after completing standard chemoradiotherapy. And as we go into the molecular targeted era in patients with the EGFR activating mutation, you can see that the progression-free survival differences are impressive when patients are administered durvalumab after completing chemoradiotherapy. So there have been no head-to-head comparisons, and the only thing we can say is that we have advances in both the surgical and the non-surgical treatment of locally advanced non-small cell lung cancer. This table highlights some of the problems we have with the induction chemo, IO, and the perioperative strategies. The percentage of patients who undergo surgery finally are at most in the mid-80%. And that's not ideal for a potentially curative disease. We also know from some of these trials that achieving a pathological complete response is very important for long-term survival. And yet we are less than 25% in the Western studies, and the Chinese study went up to PCR rate of 41%. So we would really like to have far better results as far as pathological complete response and the percentage undergoing surgery. So what are the reasons for not undergoing surgery after neoadjuvant therapy? And the upper part of the figure shows the chemo-IO arm, and you see the purple is disease progression. In all the trials, it's a very important component of why patients do not undergo surgery. And surgeon decision and unfitness is the second thing. So we need more effective and less toxic induction treatments as a companion to surgery. The EORTC consensus was published this week, but the SDS consensus is sufficient for this purpose. So you have what is commonly considered as resectable, and you have potentially resectable. So the high Ts, the N0 and N1, and you have patients with potentially resectable even with multistation N2 and bulky N2 disease. And there's much controversy between countries. There are countries where Penco's tumors are not operated upon and one tumor board with expertise. I think that's the key thing, the expertise of the surgical input in the multidisciplinary tumor board, which determines these. But this is not a group which has uniformly been included in the large phase 3 trials. So I'd like to touch on 3 different groups of patients with regards to any role for radiotherapy. So you've got the high T stage, typified by the superior sulcus tumors, where we have some trial data. And then you have the low T, T1, T2 with N1, N2 disease, where actually standard is neoadjuvant chemoimmunotherapy followed by surgery. Do you really need radiotherapy there? And that's where there's a few trials which may be interesting to follow. And finally, something I'm not going to touch on too much, operable, low volume tumors more than 2 centimeters. We're doing a trial to see whether single dose radiotherapy with a completed trial, single dose radiotherapy with single dose of immunotherapy, whether it changes the tumor microenvironment and the nodal microenvironment in a sort of priming fashion. So let's go to this first problem. It's a patient of ours, 43-year-old with a squamous cell cancer and shoulder pain, which you all recognize as a superior sulcus tumor extending outside the thoracic cavity with areas of necrosis. How should we treat these patients? Well, the 2 guidelines, the recent ESMO guidelines and the SDS, are both clear that it should be treated with concurrent chemoradiotherapy as induction, followed by resection. Keeping in mind there are parts of the world where these patients are considered incurable. And the SDS guidelines mention that while it's too speculative to use chemoimmunotherapy upfront for these patients, when R0 resection is extremely important, not only for cure, but also to prevent morbidity when disease recurs. So we did perform a trial, the INCREASE trial, where we did concurrent chemoradiotherapy with a platinum doublet to about 50 gray generally, and added dual immunotherapy, ipi-nivo on day 1 and on day 2. So this was a trial for the high Ts, where it was ingrowth in the mediastinum, chest wall, where the surgeon required induction therapy, and they were eligible for post-induction resection. We had 26 evaluable patients. 1 dropped out because it turned out to be not primary non-small cell lung cancer. And resection was performed after restaging at about 6 weeks. So the trial has now been published. And in the INCREASE trial, the waterfall plot for the 25 operated non-small cell lung cancer patients shows a pathological response rate of 60%, a major pathological response in 16%, with 24% having more than 10% residual viable tumor cells. So this seems to be an improvement of what we traditionally achieve in superior sulcus tumors with concurrent chemoradiotherapy, about 30 to 40, 35, 40% pathological complete response rates. Impressive results. As an update on the surgical outcomes is going to be, it has been submitted. And what we see is another large, bulky tumor, again, radiological stable, but metabolic near complete response, hemivertebrectomy, upper lobectomy, and no residual tumor cells, viable tumor cells in the preparation. So 26% at surgery. There were no delays and cancellations due to toxicity. Most had a lobectomy, just 1 pneumonectomy, and all were R0 resection. But any 90-day postoperative morbidity was 68%, well manageable within an academic center with expertise. The 90-day mortality was 0. We had one patient who died after that due to immune-related pneumonitis. But we decided that this scheme is not something we want to take forward, despite the high response rates. The long-term results were encouraging, but still we felt this is not ready for prime time in standard centers. What about a patient who undergoes chemo-immuno only? So this on the left is a tumor on the right, up apex superior sulcus, just got chemoimmunotherapy for 3 cycles. This is from a French publication recently published. They did extensive resection with hemivertebrectomy and radical resection in all these 6 patients. So this French series, they went on to gave chemo-immuno for these patients. You will notice just one of them had N2 disease, the rest for T4N0. Only one had a low PD-L1 level. The rest had fairly high PD-L1 levels, and they got a pathological complete responses. So is this something too premature, or should we go along this route, omitting radiotherapy and going to the standard chemoimmuno approach? So we have more trials. The case report for Yuri Ramon I just showed you. You got the Deep Ocean trial, also evaluating radiotherapy, and you got the Super trial, and there's also a Spanish trial with chemoimmuno only. So these are chemoimmuno only. So these prospective trials will give a lot of food for thought. Can we omit it? Are surgeons confident in operating on these superior sulcus tumors? And what is the level of irradical resections acceptable if the response rates are similar to what we see in the initially operable, which is only about 85% undergoing surgery? Then you've got a group of patients, the low T, T1, T2 with N1, N2, where actually chemoimmuno is the standard. We touch on a few trials in this space, which suggest that we may be able to explore a role for radiotherapy. So Dr. Al-Toki's trial has been published some years ago. He took operable non-small cell lung cancer. He gave neoadjuvant immuno-only durvalumab and focal radiotherapy. And they were randomized 30 to durvalumab or durvalumab plus SBRT. Just to keep this in context, when we give stereotactic radiotherapy to a lung tumor, peripheral lung tumor in 3 fractions, we give 3 times 18 gray. So this is a sub-lethal dose. That is a priming dose developed by clinician scientists who were thinking of based on animal models. So it's a randomized center trial. They showed a high pathological response rate with SABR added to the durvalumab, 53% versus 6%. This is the durvalumab plus SBRT arm, and these are the responses, and this is major pathological response with 90%. So single agent immuno is not it. And the interesting thing is the nodal disease. So just treating the primary tumor and leaving the lymph nodes untreated, with durvalumab, you downstaged it to N0. But these are very small numbers, just 4 patients. And in the patients receiving an MPR, recurrence of the index lesion occurred in just 11% of patients. So intriguing, is the low dose sublethal radiation actually triggering an immune response which increases the pathological complete response rate at distant nodes? And the Chinese group did an excellent trial, which has now been published as Section 01, same focal subablative radiotherapy. They gave chemoimmuno, so it's tislelizumab combined with 3 times radiotherapy. Patient had to be resectable, or again, the term potentially resectable, AJCC 8, no known driver mutations, 46 patients. They gave this, and within 7 days, they gave chemoimmuno with tislelizumab for 2 cycles, and then reevaluated and then operated. The primary endpoint was a major pathological response. And I split this into two. These are all the patients with zero residual tumor volume, residual viable tumor, I should say. And these are ones with more, 1% or more residual tumor volume. And you can see that major pathological responses also in a substantial percentage. And we had also patients who had residual viable tumor. So this was very intriguing data suggesting in a randomized fashion with chemoimmuno that giving focal radiotherapy, well, it was not toxic. That's the first point. The RU resection rate in the section 1 trial is 96%. Major pathological response at 76% and complete response at 55%. Higher than what we would expect with standard long drawn-out chemoradiotherapy with far lower grade 3 toxicity than we saw in the increased trial of ours. And what you're probably interested in is the N0 major pathological response of 65% and a complete response of close to 40%. So there is some consistency with Dr. Al-Tawki's study that even in this group with multiple N2, you can achieve pathological complete response in a third of them. So the Chinese are now proceeding. They have already gone into a large randomized phase 3 trial, the section 2401 trial. We have data at the ELCC with low-dose radiation with ivonescimab, which is a antibody targeting VEGF and PD-1. And I think that this is a very intriguing area, and the phase 3 trials are awaited. So in the meantime, we've argued, and this is in press in the journal Thoracic Oncology, we have to look at the biology to select the neoadjuvant strategy. If the biology is favorable, high PD-L1 and to nodal disease, or is the biology resistant, PD-L1 negative, which tends to do worse with induction chemoimmuno, those with actionable genomic alterations which can be targeted, KRAS, STK11, KEAP1, resistant biology, then you look at the local risk. If the local risk is low, we've suggested perhaps it's upfront resection and adjuvant chemo with or without target therapy may be the way forward. If it's sensitive biology and low local risk, chemoimmunotherapy as standard. If the local failure risk and morbidity by failure is high Ts, borderline resectable, we would argue that chemoimmunotherapy or chemoradiotherapy with a preference in our surgical group for N2 bulky and risk for R1. Well, it's for the surgeons to tell us that. And of course, if the biology is resistant, we would aim for chemoradiotherapy. So there is maybe a role to explore radiotherapy in some of these neoadjuvant strategies. It was rather controversial when we made this plea in 2023 that the MDT should reevaluate resectability more than once. So you have the initial MDT evaluation of resectable disease, but if you are unresectable, borderline resectable, we've argued that you could reassess it and reevaluate it after chemoradiotherapy or in the mid-bridge study, chemoimmunotherapy. We have ongoing crowd study where we are going to treat 28 patients to see how feasible it is after the standard chemoradiotherapy is 60 gray, whether we can resect it and resume durvalumab. So de-escalation of treatments may have a role, but I think this is an interesting study, the crowd, to see whether we actually can help some of these borderline resectable patients. So I'd like to acknowledge my lung cancer patient research group. The lead is Professor Idris Bashe on the left, and the surgical lead is Chris Dickhoff, and my colleague Famke Schneiders is running the immunology labs, which does all the translational immunology to see whether we can, on the basis of tumor microenvironment and other circulating biomarkers, help tailor treatments in future. Thank you, and I look forward to your questions.
Thank you very much, Professor Senan. Um, I hope that everyone managed to hear and see that fully. In the Q&A, we don't have any questions at the moment, so please do post some questions. Um, I have a question for you to get things started. You're very impressive data in terms of sensitizing radiotherapy for in patients having chemo IO. Is that in chemo IO with a perioperative intent, or was that chemo IO with a neoadjuvant intent? And then my second question is, the data's so good, why are we not just doing it on a larger scale? What are the downsides?
Probably the second question is more relevant. I think the science is quite weak, so we need to wait for the phase 3 trials. I know there are a couple of European initiatives as well to look at this low dose focal thing. I think the biggest challenge is superior sulcus. We've never managed to do a randomized trial. We're involved in a European initiative, but that might be a way forward if it shows that this low dose priming could take place in a single arm study. I think it will increase the surgeon's confidence in adopting low dose focal for other borderline patients, because I guess superior sulcus tumors are considered the extreme. And I think appreciate you repeating the first part of the question, why, whether it's incidental and let's see where it goes, as opposed to a strategy where we should.
Yeah, in terms of the strategy, I mean, if we're going to, in the UK, if we're going to plan perioperative intent for resectable, locally advanced lung cancer, we have to plan perioperative from the beginning, or we plan a neoadjuvant regimen from the beginning. Do you have any studies looking at the role of radiotherapy in a perioperative versus a neoadjuvant setting, as in you deliver adjuvant IO afterwards, or is the complete response rate so good that you don't need to deliver an adjuvant phase?
Just there are a couple of trials, small randomized trials going on. We don't have the evidence. For us, it's a tumor board. I think one thing has changed is that people are seeing this as a continuum where you have to reassess. So what currently happens is that the surgical team is always involved in the discussions, and they say, okay, it's primary resectable. Then it's simple. It's chemo IO, or sometimes with N1 disease, there's this discussion, can I take it out? And will chemo IO make it more difficult? So it's a call for the surgeons in the MDT. So we're very comfortable with that because all our toxicity is known, above board, transparent. So if the surgeon says, look, I want to do a sleeve and I'm not sure, we're a bit worried, then we get to the discussion, should do chemoradiotherapy to 50 gray and a resection. But then immunotherapy is not reimbursed in that setting, adjuvant. So you really have to find something intraoperatively to, to justify that. So it's a bit of a gray area. And the
Yeah.
crowd study is the only one where we, after chemoradiotherapy and surgery, allowed to go on to development for 12 months. I think the reimbursement question is probably playing a role but more importantly for patients is the surgical expertise. It surprises me still that people see a superior sulcus tumor and do not refer to a major surgical center and say this is palliative. I think that's, but I think we shouldn't move without trials. But I'm afraid that the landscape is changing so fast that even for superior sulcus, I think things are changing without the trial data.
For sure. Actually, that leads on quite nicely to the next question from Dr. Bass. Um, in how do we increase the selection of suitable patients using MGT meetings? Because many centres still lack the expertise in these fields. Do you think that this should be centralised in a more to more practically achieve ultimately the best response for all patients?
Everyone's busy, but I would suggest that, for example, the EORTC consensus or what is borderline, those are the patients you should do an online virtual tumor board, collect these cases once a week and do it on a virtual tumor board with an expert center. It's not realistic to say that everyone has to be, all the expertise has to be present at all centers. It's simply not. But if you could work out something and said, okay, this is the borderline resectable group. And these are the sulcus superior tumors. You cannot give an advice unless you I don't know, tier one or tier two, whatever you want to call it, center that says it's not. And these things are sometimes can be done virtually and you can manage the workload. My surgical colleagues are extremely busy right now because of all the interest. So I suspect they too would appreciate having some filter. And I think the URTC guideline, well, not recommendations, but document actually gives us I think, where we can perhaps focus, make use of expertise that's available because too many of the smaller centers may just see one or two of these patients a year, and it's not a good situation.
Yeah, for sure. I mean, even in one of the big, we're the biggest centre in the UK, and we still don't see that many. You know, we do them, but you can count on two hands the number that you probably see over a 6 month period. Um, and the next question, what's the gap between your induction treatment and surgery? Is it sort of a standard 6 weeks? Do you have a particular time frame? And how many patients get delayed in that gap, actually?
Oh, 4 to 6 weeks. I cannot recall the increased trial, but I think it was up to 6 weeks. But I thought, well, I don't have the numbers. It's going to be presented. The sweet spot seems to be between 5 to 6, around 5 weeks. And there's very close monitoring, pick up problems, immune-related toxicity, which cannot be, and we repeat the contrast-enhanced CT.
Mm.
And just like in the ISLC guidelines, the absence of any failure, the default decision is to go ahead with surgery. So the surgical team is actually very important, and they are on top of it. And we don't want to lose patients. So I think we'll have to look at the national data to see how many are dropping out, because there's concern in parts of America that patients are being dropping out of this trajectory. But it comes back to your very first question. Do you just start with chemo, immuno, and let's see how it goes? So you make a decision. This is operable. This is potentially operable, but this is operable, but I am worried about R0, R1 resection. So the strategy is crucial. I think that first step is important to minimize delays, because then the delays may be really in a subgroup where you really have to think hard, and the patient condition may preclude things, and then you want to put in plan B with this radiotherapy, high dose. Yeah.
And did you see an increased immune toxicity in the patients having radiotherapy versus the ones who didn't?
I'm sorry, I didn't
Did
quite
you
get.
see any increases in the immune toxicity from the ones having radiotherapy versus the ones who didn't have radiotherapy?
Um, from the increase we did see, the usual things you would expect: hypothyroidism, where I think believe you had a pancreatitis, an autoimmune pancreatitis. Most of them were manageable, except the pancreatitis, I think, went to ketoacidosis. But it's coming, it's in the publication, but I think it's the expected. So immune toxicity was one of the, in the overview, reasons why people are dropping. And I've learned this week that decrease in lung function, especially the diffusion capacity, seems to be a matter of concern. So you really need an expert team to decide whether to go or not. And if they're manageable toxicities, then I think planned surgery should go ahead.
Perfect. We have one last question regarding PD-L1. Do you consider PD-L1 in terms of deciding whether or not to proceed with chemo IO in the low PD-L1s? And do you have a cutoff? What are your thoughts on that?
So for us, if PD-L1 is low, then we'll go to using pembrolizumab in the induction chemo scheme. It does play a difference. And in the chart I showed you, the box where we make decisions, PD-L1 negative patients where we do take it all falls into the bad biology group, and you may decide if it's primarily resectable to take it out as opposed to an induction therapy, go for adjuvant. So we are conscious of that, but that's our sort of working routine scheme. But while we wait for data to come out from trials.
Fantastic. Well, thank you very much. I don't think we've got any further questions. So thank you so much for an excellent presentation, really insightful and some fantastic work. So really looking forward to seeing your phase 3 trials as they're published in the next few years. Thank you for taking the time in your busy schedule as well to come and present to us today. Wish everyone a great day.
Thank you.
Thank
Bye.
you.